they started treating thyroid cancer also. And this is how the radioactive iodine was administered, and then it was the counts were counted, unlike taking a scan currently. And this is the first publication from the magazine The Life, where first patient who was treated with radioiodine, and the two photographs of the patient before and after radioiodine therapy was demonstrated. So like once the radioactive iodine is administered, it will go and deposit into the saliva. I mean, ideally the target is the thyroid gland and thyroglobulin expressing cells, and it also deposits in salivary glands, stomach, intestines and bladder. And this is a small example of how radioactive iodine works. Like we administer radioactive iodine, it gets localized. If at all there is a small remnant tissue, we take a post-therapy scan, and after 6 months we'll evaluate it, and there is no evidence of the disease. So what's the unique nature of radioactive iodine? So in nuclear medicine, we use radioactive materials that emits gammas, alpha rays and beta rays, either to image or treat the diseases. So radioiodine is one such thing, like similar to lutetium, FAPI, DOTA and other things. Radioactive iodine is first theranostic agent, where the radiopharmaceutical which we administer delivers the beta rays which we treat, and similarly from the gamma rays it emits, we can image them as well. So, and its uniqueness is it doesn't need any vector or any other things like DOTA, I mean lutetium DOTA or lutetium FAPI, where to carry that lutetium 177 to particular cells, we take the help of DOTAs and PSMAs and FAPIs. So the natural biological iodine 131, so the thyroid follicle cells doesn't know the difference between the stable iodine, that is 127, or the iodine 131. It just engulfs the iodine 131, which through sodium iodide importer, which is taken up, stimulated by TSH, and then it gets organified and incorporates into thyroglobulin, where it emits the beta particles, which causes the heavy DNA damage, and thus creating the desired cytotoxic effect. So role of radioiodine in thyroid cancers. So role of radioiodine is particularly limited to differentiated thyroid cancers, specifically where follicular, invasive encapsulated follicular variant of papillary carcinoma thyroid and its subtypes, oncocytic carcinoma, and differentiated high-grade thyroid carcinoma, which express low sodium iodide importers. And similarly, oncocytic variant also express low sodium iodide importers, and we need to evaluate with diagnostic whole body scan, like how much expression is there, and based on that we have to treat the disease. So role of radioactive iodine in differentiated thyroid cancer, and we have specific roles, that remnant ablation, where we ablate the benign thyroid tissue to facilitate the follow-up, and adjuvant therapy for microscopic disease which would not be structurally evident, but biochemically it is evident. Although it is not evident structurally, we give adjuvant therapy and then a treatment of known metastatic disease. So for DTC, still the mainstay of treatment is surgery. For low risk group, whenever there is a total or near total thyroidectomy, and if at all there is an R0 or R1 resection, and subsequently we can just follow up with ultrasound and thyroglobulin measurement. So if at all, to facilitate that thyroglobulin level measurement, we used to ablate with radioiodine, but now in ATI 2025, low risk groups, it is radioactive iodine is not recommended, and similarly in low risk intermediate group, and radioactive iodine is recommended for absolutely for intermediate to high risk groups and high risk group. So there were few trials for ITA guidelines to consider that low risk group have doesn't need radioactive iodine therapy. These are like Istanbul 1 trial, where low risk DTC after total thyroidectomy, where 30 millicurie versus 100 millicurie doesn't show any difference. and Istanbul 2 where no radioactive iodine, and radioactive iodine after giving TSH, the 5-year survival free rate was similar and no radioactive iodine was non-inferior. And UK iodine or non-iodine randomized control trial based on 33 different UK centers, recurrence free survival was almost, it is non-inferior, so it reinforces Istanbul 2 trial for omission of radioactive iodine therapy in low risk. So considering low, intermediate to high risk patient and high risk patient and known metastatic disease patients, we will proceed for radioiodine therapy. So in remnant, whenever there is only thyroid remnant, if we give a radioactive iodine therapy, there is 70 to 90% chance of successful ablation, where in initial one treatment it could be around 70%, when subsequent addition of radioactive dose will around 90%, 90 to 95% will successfully ablate the tissue. And lymph nodes, 60 to 65% of the lesion will respond to after initial radioactive iodine. Pulmonary metastasis, so the effective rate is very high, particularly in micrometastatic disease. One thing to remember is radioiodine has its half-life of 8 days and its range is around 2.4 mm. So small tumor, small cells, they will respond well. So pulmonary metastasis, almost 20 to 24 of them have shown complete remission. And bone metastasis, we cannot expect complete remission in bone metastasis, but 32% of them definitely show some response. So overall in stage 3 or stage 4, the entire data suggests that they improves overall survival, in disease specific survival, and specifically to be precise, 29% of them showed. So these are few examples where when we give radioactive iodine, a patient with lung metastases and lymph node metastasis and thyroid remnant, after 6 months it showed good response. And this is another patient with skeletal metastasis and remnant, where the response was there with decreased TG levels after 6 months. So one more concept of radioiodine therapy post lobectomy. So I mean, still the surgery should be the primary thing even after lobectomy, but whenever there is complications of surgery, whenever there is recurrent range of involvement or injury, when the patient is not willing for surgery, any other complications, contraindications for surgery, radioiodine therapy can be tried. There is an higher dose, I mean, rather than giving an ablative doses where what we give higher doses, and there is almost 75% success rate in such conditions. So now, how do we prepare and dose radioactive iodine? So after total thyroidectomy, we will wait for 4 weeks, 3 to 4 weeks for the thyroglobulin hormone levels to stabilize, and we keep the patient on thyroid hormone withdrawal to wait for TSH level to be at least 30, so that it stimulates the sodium iodide importers. And then we do a diagnostic iodine whole body scan, we assess the disease status, and then we take the decision of how much dose to administer, and then we administer the dose to the patient. And after 2 to 5 days we do a post therapy scan, which has its own significance, even though there are around 50% of patients who are in certain intermediate groups who doesn't show uptake on initial scan, they will show uptake in post therapy scan. So an empirical dose is being considered, and then after one high dose, and then follow up is suggested after 6 months. So what are the basic checklist we need to consider before planning radioactive iodine therapy, and what are the things like it is contraindicated in pregnancy or lactation status, and fertility counseling, particularly if at all a young male, spermatogonia are more radiosensitive, and if at all the patient is supposed to receive higher doses in case of metastasis, more than 400 to 400 millicurie, consideration of sperm banking should be advised, and comparatively a young female is less riskier than young male of losing fertility, but still at the older age groups around 30-35, it is advised to evaluate the ovarian reserve before going for radioactive iodine therapy. And We have to evaluate how much time interval after surgery and contrast administration, post-contrast administration 4 to 6 weeks should be waited, and dietary restrictions and low iodine diet, and not that like low salt, iodine diet, but specifically avoiding seafood, pickles which high salt content, and as mentioned, like flour, wheat, all these things, bread can be consumed in India because they are not fortified. And we will evaluate certain biochemical parameters, performance status of the patient, and we look into the diagnostic whole body scan, and we proceed for the further therapy. And use of recombinant TSH. So to stimulate TSH, we can either withdraw from T4, or we can use T4 plus T3 combination, or we can use RS-TSH. And now it is recommended in low group in ATA, as per ATA guidelines, and when there are certain brain metastasis and there is intraspinal extension, long-term withdrawal of thyroid hormone is not advisable. In such conditions also recombinant TSH can be used. Coming to dosing, dosimetric approach is standardized, but no one, it is a tiresome procedure and no one does now. So we usually practice an empirical approach where ablation will be giving a 30 to 50 millicurie, and adjuvant therapy will give around 50 to 100 millicurie. In case of metastasis, will give around 150 to 200 millicurie. And we need to understand that now in case of skeletal metastasis, we need to evaluate not just the location, but also we have to evaluate the size of the lesion. We need to consider the possibility of usage of EBRT whenever required. And then post-therapy, after administration, we have to do a post-therapy scan 2 to 5 days later to identify the localization of the disease, and then we will keep patient on hormone suppression with specific target levels of less than 0.1 in high risk, 0.1 to 0.5 in intermediate, and 0.5 to 2 in low risk groups, and then we will ask them to follow up after 6 months. So we are advising radioactive iodine, but there will be certain side effects which we need to address and which we have to take care of. So one thing is, whenever there is large remnant is there is a possibility of radiation thyroiditis, when we have to take the help of corticosteroids pre and post usage of radioactive iodine to reduce that risk. And sialadenitis, approximately acute sialadenitis 30% incidence is there. Liberal hydration should be advised, and there are like guidelines to use lemon juice, sour candy, but none of them are completely like validated in any studies. Like there are certain studies showing the early usage of sour candies or lemon juice might overstimulate the salivary glands and cause more sialadenitis. And gastritis, as we saw, iodine goes and localizes into stomach. Stomach also has sodium iodide importers. We should use proton pump blockers, antacids for 1 to 2 weeks. And there are certain side effects like abnormalities of taste and smell, and nausea and vomiting could occur acutely. And long-term radiation pulmonary fibrosis is where there is diffuse lung involvement is there, and patients, if they have subsequent multiple cumulative doses, there is certain risk of it, but we should ensure that there is possible interval between those two, and we should address the cumulative dose to that whenever we are treating lung metastasis. And pulmonary function tests should be done whenever we are treating extensive lung metastasis case. And second, primary malignancy is one of the risk factor. And although like in nuclear medicine, we follow ALARA principle and justification and optimization, so that we'll give only whenever the dose is required. And for now, the ATA guidelines have suggested the data framework where we will assess at every step the disease burden status, whether the particular radioactive iodine is required or not, and then we will take the decision to administer the necessary treatment. So following the treatment, we will ask the patient to isolate depending upon the, if at all we administer high doses of more than 100 millicurie, and then they need to follow certain radiation safety measures, and we'll ask them to follow up after 6 months. So after that 6 months we will assess biochemically and structurally, where excellent response is negative imaging and non-stimulated TG of less than 0.2 or stimulated TG of less than 1, and indeterminate is between 1 to 10 of stimulated and unstimulated of 0.2 to 1, and biochemically incomplete is non-stimulated between TG greater than 1 or greater than stimulated. If at all greater than 10, it is considered as biochemically incomplete. Then we evaluate the disease burden and then do a diagnostic scan again and then take the decision of treating him again. And radioactive iodine also can undergo a process of de-differentiation, where initially it might be showing radioactive iodine uptake, and as time passes by it can show, like it can, due to the activation of MAPK pathway most commonly, it can undergo into the de-differentiation. It won't show up iodine uptake, and then similarly it's called a flip-flop phenomena, so where FDG uptake increases and iodine uptake decreases. And also the patient will be considered as radioiodine refractory, where immediately biochemically if the patient will progress before 6 months of administering radioactive iodine, and also if some doses of radioactive iodine are some lesions are expressing radioactive iodine that are avid previously, which turn out non-avid, all these considered as radioiodine active refractory. These are my references, and thank you.
Dr. Surya, if in adjuvant setting, expert like you advise 100 millicurie of radioactive iodine, and we have two centers. One center is admitting the patient and giving 100 millicurie at a one stage, and another center is giving 30 millicurie for 3 times. So does it affect the overall survival or effectiveness of the radioiodine treatment?
I mean the better, I mean
For
based on the
patient, it is equivalent or something is inferior to
inferior, sir. Like first dose, 100 millicurie is better than giving 30
for
millicurie.
overall
I mean,
effectiveness.
yes, yes.
Okay, thank you.
You should only refer your patient to the center which is giving 100 millicurie, because 30 millicurie there is no protocol like that. I am aware that there are centers who are doing this. That is a big no. In fact, they are causing more damage than service to the patient. Yeah, because not all centers are approved by the AERB to give therapy. So few centers can get low dose. For low dose, it is general, you can just get it. So therapy ward is required. Therapy ward is not with all the diagnostic centers. So few diagnostic centers, they follow this. It's completely non-academic. I mean, Dr. Bal is a professor here. If he comes,
scientific reason is this, what he told regulatory reason, but scientific reason is that if you give 30 millicurie, so there will be radiation induced damage to the thyroid cell, there will be sublethal damage, and then the transporter will be down regulated, then subsequent dose 30-30 you give, this will be less effective. So the first dose is the best dose. If you want to give 100, give 100. Don't give 30, 30, 30. This is sheer wastage of resources.
Thank you, sir. Thank you.
Thank you so much, Surya sir.
Thank you.